It's great to be with you. This is a really special meeting. This is actually my first time at a ThyCa meeting. It's different than a lot of other meetings I've been to because we have patients, which is exciting. Often physicians go to meetings where we're teaching each other, but it's great to have you here. I've been in the meetings with you all day, and there were a lot of questions that came up over the course of the day, which were just wonderful. So feel comfortable raising your hand if you have any questions about the material that we're going through. I don't mind if we go back a little bit or we have to review something again. That's okay. I want you to feel like you've gotten something out of the lecture. Okay, the first thing we're going to be talking about is we're talking about Afirma thyroid analysis. So first and foremost, you're familiar with the fine needle aspiration. Okay, we have these thyroid nodules that are extraordinarily common. We make an ultrasound assessment as to whether or not the nodule is concerning in appearance, knowing that there's a lot of nodules that are not particularly concerning and can be left alone, but some of them aren't and need to be biopsied, and that's known as the fine needle aspiration, and you're all familiar with that. However, when we do the fine needle aspiration, there's a variety of different diagnoses, or rather findings, that we can get from the pathologist. Okay, it's not just benign or malignant, and in some cases we have an indeterminate finding. And unfortunately, up until this particular Afirma technology or advancement, we haven't really had much that we can offer these patients, and they would end up going for surgery. And I'll explain that a little bit more here. So there are about 525,000 fine needle aspirations that are performed annually. They're sent to a pathologist, and we will get generally one of 4 diagnoses. The one on the left, the one on the left is not really a diagnosis. It's more of a non-diagnosis. It's where there's insufficient sampling, where either the nodule itself or the clinician didn't get a good sampling, and so as a result, they just say no result. Benign incorporates about 60 to 75% of the time we get a benign finding. About 5% of the time, the pathologist says the nodule is malignant. It's this section here in yellow that we're going to be talking about. About 15 to 30% of the time, the pathologist sends back a report that says indeterminate. Now, there's different types of indeterminate, which we can go through later if there's time, but what that basically means is that the pathologist isn't able to come to a definite conclusion as to whether it's benign or it's malignant, and so they say that it's indeterminate. So up until this point in time, what we've done with indeterminate findings is we've sent these individuals for surgery up until just a few years ago, meaning that we would actually refer the patient to a surgeon to have either a hemithyroidectomy or total thyroidectomy, more so for the purpose of diagnosis rather than treatment, because we couldn't make the diagnosis from the fine needle aspiration. What that meant was that a very large number of people were going to surgery yet finding that they actually only had a benign nodule. So this slide kind of highlights the fact that there are a lot of different complications which you're familiar with from thyroid surgery, which aren't trivial. We often say that this is, it's not that big of a procedure. Sure, there are more involved surgical procedures than hemithyroidectomy or total thyroidectomy, but there are still complications, and I'm sure you've heard some of those today. In particular, vocal cord injury, hoarseness. Sometimes as a result of the surgery, thyroid hormone therapy is needed, and many others. So what we're trying to communicate to you tonight is that with this new advancement, what we can do is reduce the number of unnecessary surgeries, the number of people who go on and have surgery to remove the thyroid or a portion of the thyroid simply for diagnosis. This can be done usually from the first fine needle aspiration. I heard a gentleman say today that he had one biopsy and then he had another biopsy and then he's going to have a third biopsy, and we usually can do this off the first one, and I'll explain that in a moment. So here's how it works. So you see your endocrinologist or radiologist, whoever is going to do the biopsy, and usually on that first visit for that FNA, 4 passes, needle passes are made. I routinely make 4 passes. The first 2 needle passes go to the pathologist, okay? The second 2 needle passes, the material is rinsed in a small solution, and that solution is also sent with the initial specimen, and it's more or less kept on hold and may not be used. If the pathologist renders a diagnosis of malignancy, no further testing is done, the results are communicated, and of course the patient will be referred for surgery at the clinician's discretion. If it's benign, so also that result is communicated. If that result by the cytologist or the pathologist's interpretation is, I'm not sure what we're looking at here, I'm going to call this indeterminate, then that extra tube that's sent from these 2 passes here are sent for what's called a gene expression classifier. Okay? And so this is an advanced molecular analysis that's done, and I'm going to go through that. So what we're looking at is a gene expression signature. So in summary, what's been done over the past several years is a lot of very good research to identify a certain genetic fingerprint, if you will, of a benign thyroid nodule. So the material from your thyroid FNA is matched up against that particular benign signature, or fingerprint rather, to determine if there's a match. If there is a match, as this kind of demonstrates here, you can see that this grid cube thing is the same as that, then we can say that fingerprint is the same as a benign fingerprint, and that's a benign finding. Turns out it's not always a benign finding, but almost always. So what we're doing is we're taking an individual patient who would have been sent for thyroid surgery to remove half of their thyroid gland to determine if that nodule is malignant, and instead of sending them for surgery, I call them on the phone and tell them that it's benign. Okay, it's a tremendous thing that we're now able to do. In some individuals, it doesn't match up. When it doesn't match up, we're not necessarily communicating to the patient a diagnosis of malignancy. We're saying that the risk of malignancy is elevated, and in that case, surgery is generally performed. But what we're able to do is select out those patients who don't need surgery, and we can save them from unnecessary surgery so they don't have to have that experience of going back into their surgeon's office a week later, checking the scar, everything looks good. By the way, we didn't really need to do that anyways because it was benign. So this is a kind of a slide that kind of summarizes some of these numbers. So the challenge, of course, here is we have all these patients who have an indeterminate pathologic diagnosis, and surgery is performed only to find that about 1/4 of these have malignancy, but 3/4 of them had what we now can say was avoidable thyroid surgery and unnecessary surgery. Okay? So the solution here is this Afirma testing. So the indeterminate diagnosis, the testing is run, as I mentioned. About 50% of those patients will end up having a benign finding, and about 50% are found to have a suspicious finding, and in those individuals, they do end up needing surgery. But what we've done is we've dropped this number of patients who now have to have surgery very, very significantly. Okay, I want to stop there for just a moment and see if that's actually a lot of information in a very short period of time. Please, questions?
I don't have a question. I think it's brilliant because I was one of the, personally, I know I'm talking personally, I was the 20% chance of cancer indeterminate, and I decided I couldn't sit on it for 6 months as my first doctor recommended.
So they said come back and have another biopsy, you saying?
No, my first doctor said wait 6 months and we'll look at it again. Oh, sorry. And I chose not to because I'm just not the kind of person who could sit on something like I might have cancer, I might not. And he said 20% chance, and I thought, well, if it was you're talking rain, I might not take an umbrella, but this is my life, so that changes the odds and the seriousness of it. And so I personally made the choice to go ahead with surgery. And I personally had half of my thyroid taken out, and they couldn't still confirm in surgery that it was cancer. And then they closed me up and sent it to the lab, and then it came back as cancer. And I personally now am thrilled that I caught it so early, and my gut said, get rid of it, go ahead.
Yeah.
But this kind of thing would have saved that one step where I was. So I think it's brilliant.
Yeah, that's great. Great comment. Over here.
The one question I have is that, you show, benign or malignant, and if you're coming up as malignant, you're not testing.
That's correct.
But you can also have false negatives. So wouldn't it be the patient's best interest to double
False-
check?
False.
A false benign showing from the pathologist.
A false. You mean if the pathologist says that it's
That it's benign, but that's not true.
that's
I
a-
know it doesn't happen often, but in the cases that it does, it makes such a drastic difference in that person's life.
There's a couple of different. I know. I hear you. There's a couple of different answers.
Some people in here know who I'm talking about, so.
A few different answers I think you can give to that comment or question. First of all, you're right. There is a false negative finding with cytology.
Mm-hmm.
It's not perfect, nor is the Afirma classifier perfect. And there can be false negatives and false positives as well, though those numbers are very, very satisfying. It hasn't been validated or tested in that population. It's not. You're dealing with if we then did the classifier, you could say, well, that's not 100% perfect either, right? So we're dealing with very close to 100%. False negative rates are in the order of about 3%, depending upon the institution. Yeah, we're close to 100% though, but I understand there's still going to be, for those patients, and they're out there, and I know many of them who, even if there's a slim chance, they kind of want it out anyways. But in this case, I think the accuracy of cytology is good enough that if the pathologist claims that it's benign, it almost always is.
Mm-hmm.
Good comment. Any other questions or comments about that?
I'll wait for this. Thank you. I'm kind of on the same wavelength. It's hard for me to sit back and say, well, because mine were indeterminate, okay, with my first biopsies. And, I described it in another session that he pounded away. I was, numb, so I can't speak to what was going on there. I don't know if it was fine. Didn't know the vocabulary then. I don't know if it was fine needle then or not. Mm-hmm. But he did at least 2 to 4 samples, and it was indeterminate. And I guess with my history, radiation at 8 months old on my thymus, okay. So in the 50s. So maybe that figured in, but I mean, I don't remember, but I guess they went ahead and did surgery, and it was papillary stage 3.
Okay, and this is about how long ago, if you don't mind?
08.
2008. Right, so, prior history of radiation to the neck, it changes our threshold for consideration of biopsy. It changes the way we think about that indeterminate finding. And I probably would have advised the same thing at that time with that history. But
let's move on now. We'll have time at the end for some questions, okay?
okay, very good. I think I have one other slide maybe. Okay, so I guess this just more or less kind of covers that there's different things we can do with that result. If the Afirma analysis shows that we have a suspicious finding, that doesn't confirm that it's malignancy. That's a very, very important point. It just means that we're saying it doesn't look like it's benign, but we're not certain, and we still need to proceed with surgery. So many people will pass through this process, have the Afirma analysis done, and still need to have surgery. In that case, sometimes it will be lobectomy. Generally, if it's kind of up to the clinician's discretion. If it's a pretty suspicious-looking nodule and there's some on the other side, it may be a total thyroidectomy, but generally speaking, most physicians with a suspicious Afirma finding are recommending that hemithyroidectomy be performed. But those are some of the options.
When there's a suspicious finding, what percentage of those are actually shown to have cancer?
With a suspicious Afirma finding, it's approximately 50%. These numbers vary a little bit from place to place depending upon the prevalence of thyroid cancer in that population, but it's approximately 50%. And that's generally the number I use for patients. And they say, well, it's not 100%. I say, no, but it's high enough that this isn't something that we'd want to just go on and watch and just come back in 6 months or a year and just have another ultrasound. At that point, we're not talking about a 10, 15, 20% risk of malignancy. It's at least 50% generally. Okay? Okay, and then just a couple of other quick things. So we can identify medullary thyroid carcinoma through the Afirma testing, and also we have the ability to do specific mutation analysis that this company VeraSite can offer through the Afirma testing. Your clinician can determine if they want to move that 50% number up perhaps or down if we have BRAF testing, which is a whole nother topic, but it's a specific mutation that if found virtually confirms that there's papillary thyroid carcinoma. If it's negative, you're still back with it. It could still be thyroid cancer, but if it's positive, it definitely is. So that's an option as well that's offered. Okay, I think that's our last.
All right. Questions? I owe you a question. Okay, I owe you a question.
I'm just curious, when you did all of this information that you're presenting and how many people you've tested this on and all of this information you've presented, like when...
So when did I... So
yeah,
number
has this
of people that
just been like the last 6 months that you've come up with this information? Or?
This has been in use 2010. Where are we at with 2010? I think I started in the end of 2010 or beginning of 2011. I heard once I was the first in Oregon. I don't know if that's true, but I've been using this now for about 3 years, almost since its inception, routinely. Very rarely would I send a patient to just have the biopsy performed and not send along a specimen for possible Afirma analysis. The slides were prepared recently, but
the numbers you present, like as far as this is this, is that like 100 people that you've done this on?
This is very high quality, high level, multi-centered, across the country data that's been published in high level reputable journals, and this technology is being used all throughout the country in major institutions, Johns Hopkins, University of, I can go on and on and on. This is not a brand new thing that I'm using. It's very, very commonly used. Did that answer your question? I don't know if I... Yes. Okay. Good.
Are you shy? Questions? I have a question. Liz, if anybody in the room has questions later, so they're back in their communities and they get a question from another patient in the community, where can they go to get additional information or support for Afirma?
Great. Yeah, if anyone's interested in getting more information, I do have a list of our representatives who are available, so you could look to see who's in your area, and I have their contact information. So just come see me afterwards. I have the list in the back. And then also you can look on our website, which is afirma.com. And right now it's mostly content for physicians, but we're going to be launching patient information in about a month.
Great. This is Liz. She's in marketing with VeraSite. Sorry.
No, I thought I heard you say that they do this for measure. I didn't know that.
Oh, I didn't say that.
You said that.
What did I say?
The slide said that.
What did the slide
You
say?
also test for medullary cancer?
Medullary thyroid carcinoma can be picked up. A lot of times your physician might order a calcitonin, which may pick it up in advance. But yes.
Here's one. I think this is the first question in the back table.
Oh, yes, we're not silent back here. I'm from Canada, from the province of Ontario.
Great.
And I had the unfortunate experience of having 3 FNAs that were non-diagnostic.
Okay.
And finally, the 4th one gave atypical cells, which then rendered me feasible to be able to have surgery done in Toronto. So the whole process took about 15 months, and a lot of anxiety. Even once my thyroid was removed, I waited for over 4 weeks for that pathologist. I was fortunate to be able to speak with the pathologist, Dr. Sylvia Azza from UHN, from Princess Margaret, and she explained to me that all the multiple FNAs had actually made it more difficult for the final diagnosis of my cells. So I guess my question would be, would any of that help if there had been already FNAs done previously? And I think from talking to Liz already out in the lobby that I believe this is not available as yet in Canada.
She'd be able to answer that last part better than me.
Over there with it.
But the first part I can answer.
I'm getting my exercise.
You sure are.
Yeah, good question. So in terms of international, if you have any questions from people internationally, we are slowly expanding international. We do get some cases from Canada. We're not part of the national health system yet. Working on it, but not there yet. And so we can work with the patient on payment and so on.
And I think your question regarding, that's an unfortunate experience to have that length of time that you had to wait for all this whole process. So we used to, not that this has changed completely, but we used to be of the opinion that if we did a fine needle aspiration, we caused enough trauma to the thyroid nodule that we had to wait a period of about 3 months before the FNA is repeated. There was a study that came out about 2 years ago or so that kind of refuted that. And they had some pathologists that looked and said, we're really not seeing that much effect from the initial FNA. I've heard differing reports from pathologists on that fact as to whether or not there really does need to be a lag time. I feel like the data that I've read is sufficient enough that if for some reason a second needle biopsy is needed, perhaps I'm referred a patient who had an FNA done just a month prior, I'll usually go ahead and just do it that day. But some people think that there needs to be a little bit of a wait time.
All right, Dr. Hungerford, I think we're going to need to move on to
Yep.
Thyrogen,
Okay.
but thank you for presenting this information. It was very interesting and helpful, I think. Liz, will you be around afterwards if there's any questions about Afirma?
Yes, definitely. I'll wait for that.
Okay, thank you.
Does I don't know. Thanks.